So we're glad that the AOC decided to help us out with this endeavor to try to get the students at least some ability to talk to someone from the program so that they have the opportunity to at least see them and get to know them and maybe ask questions about the program, what they do, how they are, how they operate, the area, those kind of questions. So special shout out to all of the participants here, Dr. Skinner, Dr. Chowdhury, and I believe someone from Ohio Health Doctors Hospital will be on shortly as well. So if I see them, I'll point them out as well, so we can kind of point questions towards them or just the panel as a whole. Also, a special shout out to Blake Karachi for helping me set this up from the student perspective so that we have a good showing so that people can come in and ask these pertinent relative questions. So what I think we should do, Dr. Chowdhury, why don't we start with you? Just give us a quick, brief introduction to your program and any special characteristics about it, and then we'll kind of do that with each of the programs, and then we'll open it up for questions.
Hi, how are you guys? Can you guys hear me?
Yeah.
Good, thanks. My name is Faris Chowdhury. I'm one of the associate professors at Riverside University Health System. As you guys know, we're the largest osteopathic anesthesia residency program in the country. We're now fully ACGME accredited. We're located in Moreno Valley, California. We have about 5 residents a year that we take. And we do have our core rotations at our hospital, and we do our outside pediatric and cardiac rotations at CHLA and Cedars-Sinai, respectively.
Perfect. Heidi?
Yes, so I am with a small, traditionally osteopathic program in Dayton, Ohio. We're part of Kettering Health Network. We operate primarily out of Grandview Medical Center, which is a community health center, but has about a little over 300 beds. We also do more ambulatory surgery stuff at Southview Medical Center, which is about 10 minutes away. We do pediatrics here at Dayton Children's, which is 5 minutes away or so. And then some other things around the other hospitals here in town, but everything is here in Dayton. We are a fairly small group, but we have 3 residents per year. No, if I was gonna say, you guys are more than welcome to ask any other questions or anything like that.
Perfect.
Oh, and I'm one of the residents. Our program director and associate program director are currently on an airplane, so.
That is fine. I haven't seen the Doctor's Hospital one show up, but I can kind of speak to that briefly. That's where I did my rotations. They are both a small community hospital as well as a level 1 trauma center. They typically admit 2 applicants per year. Most of their stuff in their CA 1 year is done at that smaller community hospital, and then from there, different rotations split out, but they do go to their large level 1 trauma center downtown, so they kind of get the best of both operations. They do lots of orthopedic stuff, so nerve blocks and regional is something that they are doing a lot of. So that kind of speaks to them a little bit. So guys, use the chat icon and we'll just throw some questions out there. But until we get one going, Dr. Chowdhury, one question is, and you both can answer this, call schedule. What's your guys' typical call schedule like for the residents? Is it a weekend a month? Is it a rotating every 6 days? How does that work?
Well, we employ currently a night float system where we'll have residents cover nights. We usually have 1 senior resident and 2 junior residents, 1 to 2 in-house. So that's usually about every week. It'll alternate. So we're still in the process of potentially readjusting our call system, but it will be a Q6 if it was a Q6 every night, or Q5, depending on how many residents we'd have in-house. We have CA2s that do outside rotations half of the year. So depending on what time of the year it is, it could be every 6 days or every 5 days. But at this point, we've employed a night float team because we actually want to give that choice to our residents, whether the residents want to have a night float team or a 24-hour queue call shift. This year, they've chosen to have a night float shift. So about every week, We have a senior resident and 2 junior residents on the night float shift. And the calls come out to about every fifth week you're about to call.
Perfect. Heidi?
Yeah, so we do not have night float. We did kind of mull that around this year, and as residents, we decided, you know, that it wasn't something that we necessarily wanted to do, but it's something that we could do in the future. We typically you are on call for 24 hours. If it's a weekday, then you're working that day, and then you're just kind of the last one out of the OR. It's about 50-50 whether you get called back. We do take home call, so you've got to be within 30 minutes of the hospital. And about half the time you end up getting called back for something in the middle of the night or a trauma, or we do an acute pain service as well for hip fractures. So anytime hip fracture comes in, we go in and block them in the ER or on the floor. Typically, it's actually very variable. CA 1 year, you can count on about 5 or 6 primary call shifts per month. Once you're heart trained, about halfway to 3/4 of the way through your CA 1 year, then you start picking up a couple backup call shifts, and you only get called in backup call if, you know, the primary call person is already working, or we take call for both Grandview and Southview. So sometimes one will be at Grandview, one will be at Southview. So there's always 2 call people, the primary and the backup call person on. Usually the backup call is a more senior resident. So you typically, CA1, you take 5 to 6 primary call shifts a month. As CA2, you take about 4 or 5 primary call shifts a month on the months that you are in-house, because again, about 4 to 6 months of CA2 year, you are on out rotations at Dayton Children's or doing chronic pain or things like that. So when you're in-house, then it's usually about 4 or 5 primary call shifts a month, and up to, depending on how many people are in-house and how many residents we have, because in my year we have 2 residents, and my seniors have 2 residents as well. So once we have 3 residents in every class, then call will be a little less, but you can count on between 6 and 8 backup call shifts per month as well. We do get post-call days off, so that's a bonus, and we also get paid a little bit extra for taking backup calls, so that's kind of built-in moonlighting for us.
That's fantastic. Dr. Cook from the UPMC Lidditz program is here, so she's going to introduce her program and then also speak to that question.
Hi guys, can everyone hear me?
Yep.
Yes.
All right, I'm Danielle Cook. I am a CA2 at the UPMC Lidditz residency program. UPMC Lidditz, all of our programs are based right in Lidditz, but we do some outside rotations in the at Hershey Hospital, and then we also go to Harrisburg as well. We're kind of ingrained in the whole UPMC system, so we do a lot in Harrisburg, and we can also go to Pittsburgh as well for electives if we choose to. The hospitals that we have to travel to, Hershey's about 20 minutes away, and we do rotations like trauma and neuro there, since Lidditz itself is a smaller community hospital. And then Harrisburg we go to for hearts or any other type of intrathoracic type cases that we need to get. We've got very good relationships with those programs. As far as Lidditz itself goes, we spend most of our time here. We take 2 residents per year, but we're working up to 3 residents per year actually. And it's just a small community feel, a lot of autonomy. You get to do all of your cases yourself, which is really great, and one of the reasons I chose the program. As far as call goes, just to address that question, we do things a little bit differently when it comes to call. You actually start call your intern year, and that is primarily because we've changed the curriculum a little bit to give residents 4 months of anesthesia specific rotations in their intern year. And then we do a couple of the other like internal medicine rotations your CA 1 year to make up for the fact that we get you on board with anesthesia so early. So we start off the first few months where you're just taking buddy call. You'll be paired up with the senior resident and be doing call cases with them. And then after about 3 months, you're taking call on your own one-on-one with an attending. So you get a lot of hands-on experience very early. You get very comfortable with anesthesia at an early rate. And I think that kind of gets everybody a lot more confidence as they go on to more difficult and more challenging rotations. So call is usually there's 8 of us. So if you're on an out rotation, let's say you're doing like Hearts in Harrisburg, you're taken out of the call pool just because you have a little bit more of a commute, and that way you don't have to, get called in for things going on in Lidditz. Your responsibilities are elsewhere. So calls usually like once every 6 days or so, with your post-call day completely off. So if you guys have any other questions about our program, happy to talk about it. Thanks.
Lots of general questions, so we'll kind of just keep going down the list with you three. I think it's working pretty well so far. One question is kind of about moonlighting. Are there opportunities to moonlight? If so, what kind of stuff do they do, and when do they do it in the program? Dr. Chowdhury?
At this point, our residents currently do not moonlight. The opportunity, I'm sure, if it's wanted by the residents, is something that could be discussed and talked about. We actually had considered offering that to our recent CA3s who just graduated, but I don't think it came to fruition. So at this point, our residents are not moonlighting, but that is always something that's on the table.
Perfect.
So we have had senior residents in the past moonlight. We've had a couple that were actually internal medicine physicians, attendings before coming through. Or PAs before coming through the program or before going to med school. So we've had some people moonlight in urgent cares and things like that. And that's as long as it's well within the ACGME, our guidelines and everything, it's fine. But typically we don't moonlight just because we take enough backup call to kind of built in, and we have to take it anyways. So that's built in enough to sometimes come close to double our salary for the month, so we don't need to generally.
Perfect.
I agree. Our program is kind of the same way. You're kind of busy doing your own thing with anesthesia, that there's not a whole lot of opportunity to moonlight. But with that being said, the people who have done some moonlighting actually will moonlight more urgent care or internal medicine with our other internal medicine programs and things like that, and get their extra pay that way. But honestly, most people aren't all that interested in moonlighting, so it hasn't been too much of an issue with our program. But the opportunity's there if you should want it.
Fantastic. One thing that I think is probably pertinent to every program that a couple of people have been asking is, without the audition rotations, how can they show interest in your programs? Is there any tips, tricks, advice that you guys can give on behalf of the students?
Well, I think obviously it's difficult now. The best way is to come rotate, which I agree with. If you can come show interest, and we can observe you through a clinical rotation. With this weird times that's occurring with COVID, I think the best way is just to reach out to our residency coordinator, send emails, send messages. And I think constant communication is the best way to do it. If we get, an email from a candidate and 4 different emails and 4 different times they tell us that they're interested in the program and why they're interested, that's definitely something we look into. I mean, I speak to the residency coordinator almost every day, and she'll tell me, hey, this candidate has emailed us 4 or 5 times, definitely showing interest. Let's, give them a look. So I think just keeping the communication lines open, expressing your interest is probably the best way to go.
Yeah, I would agree. I don't know that I have necessarily anything to add to Dr. Chowdhury's. Of course, we would love to have you rotate through, and I know that we do have rotating students, so it's more, at our institution right now, so it's probably more dependent on whether your school will allow it and will allow travel. And if they don't, that's okay too. I would say just reach out. It doesn't even have to be the program coordinator. That's great. But also all of our residents are happy to answer any questions. And we're pretty open, and at any time our residents, our program director, and our program coordinators are very open to it. And we do make note of people who have contacted us expressing interest and things like that, that, you know, will definitely be taken into consideration.
Yeah, you guys really said everything. It's the same with us. Just reach out to us. The residents receive emails all the time from people answering questions or just giving any more information, kind of like the inside day-to-day scoop of what we're doing every day and experiencing can be really helpful. And learning more about the area and why Lidditz would be a great place to live, all that good stuff. And then we take auditioners every 2 weeks. So the best thing, like you guys have all said, is just to come spend some time with us and see if it's a good fit for you.
Fantastic. For what I'm told, because I think I have emailed your directors individually, rotations are pretty full. So there's a rather large waiting list because not every hospital is allowing that, as you guys are. Other question from the group. They have questions on amount of autonomy that they're given as residents, especially as they progress through their training. Are they able to function almost as an attending as a senior, or are they still kind of treated as a baby? And some of that, I guess, is dependent on whoever is supervising them that day as well. So
I feel like I've been going first every time. Does anyone else want to go first?
you can go backwards.
I can go, sure, I'll go.
There you go.
We'll go backwards. So I think this is actually one of the greatest strengths of the Lidditz program, so I'm really happy to answer this question. You get a lot of autonomy at our program, and because it's small, it's very individualized. So as you progress, the attendings will be working with you. They'll be able to see what you can handle. So like I said, intern year, you're starting off doing your own cases. You'll have somebody there with you to fall back on. But you're in the OR, you're intubating, you're putting in your LMAs. If there's a C-section, you're doing that spinal, you're putting in that epidural with someone there walking you through it until you're independent enough to do it on your own, and then you're free at that point. So most of the time, by the end of about 3 or 4 months, even halfway through your intern year, you're doing cases by yourself and being left in the room by your attendings with them popping in and checking on you. And of course you have their number that you can reach out if you get in over your head. But you have a lot of independence, and you learn a lot by taking call early and having that experience. So that's one of my favorite parts. And OB keeps us very busy as well. So you get a lot of experience very early with epidurals and C-sections and more complicated OB cases from a very early start. So I think that's one of the greatest strengths of our program. We have very supportive attendings who know you very well and know your strengths and weaknesses. So the autonomy is definitely there if that's what you're looking for.
Our program is very similar in that way, in that not necessarily an intern year. Usually intern year, your anesthesia months will come towards the end of your intern year, and you generally get them May and June, so that July 1st you're kind of ready to have your own room and run your own room, of course with an attending supervising. But yeah, so CA1 year, you start out with your own room, all your general cases, and basically until you hit cardiovascular. And then usually your vascular months, you'll have, maybe the first week or so, one of the senior residents in there with you, helping set up, helping kind of troubleshoot and get you a little more comfortable with vascular. And then you're kind of on your own in terms of vascular at that point, as long as you feel comfortable. And then same with doing hearts. Your first heart month, you'll be paired up with a senior resident, and as much as you can do or as much as you want to do, you're able to, and that senior resident can kind of just, as you progress through the month and do more hearts, kind of more supervise and work with the TEE, because that will be one of the things that you progress in. We do all of our own TEs as well. So you get, those are the only 2 real times that you're going to be one-on-one with a senior resident, and then of course you're attending. Pretty much any other time you are running your own room and you're attending, we do 2-to-1 supervision. So in general, your attending will be in there. Not a lot, but enough to, he'll try and come in and do some teaching and stuff with each case. especially if they're longer cases. The autonomy is there for sure. We don't have fellows with us, so we're not fighting for good cases in terms of that. All of the good airway cases and good, really good teaching cases, cardiothoracic things like that, preference goes to the residents, because we do have CRNAs that we work with as well here. But in general, you don't share cases. Your cases are your own. The only time that you'll be sharing them is if you're a very junior resident, and they'll pair you with a senior resident just to kind of get your feet wet.
Guys, I'll speak from an attending perspective. I think one of the greatest strengths of our program is that we do give autonomy to our residents, and I think our goal is to graduate residents that are ready to handle the real world. One of the, as Dr. Skinner just mentioned in her program, we also have our PGY1s finishing off their last 2 rotations in May and June, and they're one-on-one directly with a CA3 who's going to graduate, so that they're ready to fly solo in July when they start. You get very good autonomy. It's a little different when they do the outside rotations at Cedars-Sinai for cardiac. It's actually a private hospital. So when they go to do their cardiac at Cedars, they have an attending one-on-one with them, because they're basically a private group that just has residents for teaching purposes. And it's not a full resident run hospital. So they're one-on-one there. CHLA, Children's Hospital Los Angeles, they're also more one-on-one, as they're doing, very, very complex pediatric patients. But when you're at Riverside University with us on your non-outside rotations, the autonomy is pretty free. As the attendings, we'd like to see our residents progress, and progression occurs pretty quickly. We actually have one of the most interesting rotations that I find as a CA3. It's called a PR rotation. We call it PR because it stands for PACU and regional. And the reason I mention this is it actually grooms leadership and grooms more autonomy. I am originally from the East Coast, and I practiced in private practice for about 9 years before I moved out to Southern California. And in private practice, one of the most important things we did was learn how to run an anesthesia board. Know who's assigned to what room, know what time people have to go home, know what time people need to call in, know how to change assignments, know how to give lunch breaks. And I didn't have that in my residency program, but the PR rotation that we have, the CA3 is actually tasked with those. There's always an attending who is supervising that and oversees that and is always available for questions, but we usually let the resident do that. They make the assignments for the residents for the next day. During that day, they'll switch cases. If there's we do have SRNAs that come from Kaiser, and if a ruptured AAA comes into that room, they'll switch the resident that goes into the room. They'll coordinate lunches. They'll make sure the attendings are available to lunch their rooms, otherwise coordinate lunches with the residents. They're also involved in doing all the blocks in the PACU. They're doing the pre-ops and answering code blues on the floor. So that resident is basically almost in a leadership role where they're, running the floor. And I think that's a valuable experience that our CA3s also get, which I think is unique to our residency program.
That's fantastic. And it sounds like probably with all 3 of you guys answering, we have one last question. So I'll kind of merge it into 2. Odd interview season, obviously. Are they going to be live? Are they going to be Zoom interviews? And are there any specific cutoffs or criteria that have to be met for you guys to look at an applicant and say, yeah, we'll consider this one versus just, circular filing cabinet?
So I can speak for our program. Anybody who comes through and is doing an audition rotation, we typically interview them on the last Tuesday that they're there. We have didactics on Tuesdays, so we'll take that last hour and interview them. Typically the interviews are with all of our residents plus attendings, and we break out into a couple different rooms. So you'll have a couple different interviews. It's a very informal interview. We're a very informal, approachable group. So if you're here, then we will interview you in person if you're rotating with us. Otherwise, I believe we are probably doing the Zoom interviews. And I don't necessarily want to say that they're going to be one-on-one. They will probably be applicant with one or two of our attendings and one or two of our residents as well together. And in terms of, we don't have necessarily hard score cutoffs or anything like that. We like to see that you weren't anywhere close to failing. But in terms of cutoffs, we don't necessarily look at cutoffs specifically. We kind of look at the application as a whole.
Our interviews this year will all be virtual, actually, just with everything going on. We always try to incorporate as many residents as we can into the interviews as well as attending, so you can get kind of both sides of the spectrum, both sides of the experience. And then there's usually one administrator interview as well who's a part of the process. As far as cutoffs and things like that goes, if you've had a failure of any kind, usually that kind of puts your application to the bottom, unfortunately. It's just kind of the nature of how competitive anesthesia residency programs are these days. But other than that, there's no strict cutoff for us. We just like to see a strong applicant who, wants to work hard and would thrive in a smaller environment where you're given a lot of independence and things like that. So.
I think it's a little different this year because we don't have as many rotators. We have some. We usually have a cutoff of about 220, where we'll interview people who have a higher than a 220 score, but we've taken people with lower scores who've rotated with us and done a stellar job in their rotation. So the cutoff isn't a hard cutoff, but we usually like candidates with a higher than 220. We also do look at, regional interests. We are in Southern California. A lot of people like to come to Southern California. We would actually prefer people who want to come to us as their top choice. There's a lot of programs out in Southern California. So then the caveat is, if you have a 260, if Stanford's your first choice, why are you coming to us? So we do also enjoy or look at applicants who do have some connection to our program, or do want us as their top choice for whatever reason. Again, as an osteopathic residency in the past, we have a big medical school, Western. We have another one up in Northern California. We still do, and I don't mean to say prefer, but we still do look at DOs very strongly. I myself am a DO. Our program director, Dr. David Ninen, is a DO, and he was part of the first residency class at our hospital. So we actually took our first MD in the match last year. Because we are now ACGME accredited and are accepting applicants from the AOA and ACGME and ABA side. So we do have a strong affiliation with DOs as well. So.
Question for you.
Yeah, real quick, last one.
It was my question was specifically related to what he said. He said a cutoff of 220. And that's a USMLE cutoff. Does that mean that you don't accept someone who didn't take the USMLE?
No. We accept both. We accept the USMLE cutoff and the COMLEX. I'll be honest with you, I'm not sure what our COMLEX cutoff is.
That's fair enough. Yeah.
I haven't. I actually took both. I am a DO and I did an ACGME residency program, so I've taken both COMLEX and USMLE. Recently, I just know, speaking to our coordinator, that our cutoff is 220 for the USMLE, but I'm sorry, we obviously take the COMLEX. We were previously osteopathic program. I have not, I don't have the knowledge of what our COMLEX cutoff is. I'm sorry.
No, that's fine. Thank you.
Perfect, thank you. Panelists, if you feel free and if you want to, you can leave contact info in the chat so people could reach out, or program director contact so they can reach out to them with any other questions. But I want to thank you all for participating, especially the students for coming out and participating. Without you, this wouldn't have happened, and also without the panelists, this wouldn't have happened. So I thank all of you.
Thank you for facilitating. This is great.
Thank you. Did you just say we just put our email in the chat?
Yeah. Just open up the tab, throw it in there, then the students can take it down if they need it. But that way they'll all see it.
Sounds good. I'm just going to go ahead and type it in. Thank you, guys.
Hey, for everybody that is still on here, I'm looking through the questions, and a lot of questions didn't necessarily get answered. So if you want any specific questions regarding, I'm sure they would be open to as well, but our program here in Dayton, feel free to shoot me an email. I'll answer any of these as best I can in terms of, yeah, we've got some global health and programs, opportunities for research, and program strengths and things like that. So I'm happy to answer whatever you guys need. If you want to stay on here and I can answer, otherwise you can always email me, and feel free to correspond that way as well.
That'd be fantastic. I think doing it via email would be the easiest, since this isn't going to be open for
yeah. Yeah.
And did I see Dr. Chowdhury's email?
I don't.
He posted it. It's f.chowdhury@ruhealth.org.
Okay, I'm glad someone saw, because I didn't see it.
Can you repeat that?
It's f.chowdhury@ruhealth.org.
If you want to throw that into the chat, Micah, directly.
Yeah, let me go ahead and do that for everybody. Let's see. There you go. Can everybody see it?
Yeah.
Okay.
Thanks, buddy.
Oh, you're welcome.
All right, guys. Thanks for your participation. This was fun.
Thank you.
Bye.
All right, bye.
Dr. Skinner, I have a question for you.
Yeah, go ahead.
Two things, actually. Did you say you were CA2?
Yeah.
So
CA2.
if we end up there, we'll be working with you next year.
Correct.
Yes. Yep. Great. The other thing, do you have an open ICU?
We have a semi-closed ICU. That has changed significantly, actually, from when I was an intern. We did have an open ICU, so we had, you know, a bazillion and a half attendings on their own patients. We do have an internal medicine residency here, though, that typically ran most of the ICU, but it was a little mixed because there was a lot of hands in the pot at the same time. And now we have it to where our ICU rotations in intern year are with our critical care pulmonology physician who oversees the ICU. So there will be different admitting physicians, but while in the ICU, you know, like our vascular surgeon will admit to the ICU, and then while they're in the ICU, they are taken care of primarily by the crit care pulmonologist, and then the vascular surgeon would be the consult portion of it or something like that. So it has changed significantly in the last couple of years, but it is pretty much a closed ICU.
Yeah, pros and cons.
Yeah, for sure.
Right.
Yeah.
Thank you.
All right, no problem.